All right, moving right along. I want to take just a second to thank the incredible team at Penn who made this possible. Without them, we would have nothing. And Dr. Merkel did such a great job of pulling everybody in here. And Jacqueline coming down the steps, as well as Miranda, I'm going to mess up her name, were very instrumental in having us be here today. Jacqueline, yes? Okay, great. Well, without further ado, Dr. Ligon is going to talk about scleroderma and all the syndromes. Thank you so much. Okay. Do you need to mic him up? Mm-hmm. Oh, we're just going to take a second to mic up so we have video, because I believe we're going to have video after this on the web so that you guys can review it or share it with your community.
All right. So my name is Colin Ligon. I appreciate the opportunity to talk with you guys today. I apologize. I brought a frog with me today. I also use a little bit of shorthand. I'll give you a word of warning up front. I'm abbreviating wherever I possibly can. This is one less opportunity for me to squeak if I say scleroderma instead of systemic sclerosis, but that's very much what I mean with that terminology. So I just wanted, I'm one of the rheumatologists here, recently started at Penn, and wanted to take a moment to orient you guys a little bit to a common question that we get, I think particularly early in diagnosis. In rheumatology, we get very comfortable with a lot of gray area in disease, and we get used, I think, to this idea that very often individuals have more than one feature of a disease. I think that can be intimidating, sometimes scary for patients, especially when you're kind of coming around to those initial diagnoses, trying to figure out what to expect in the future. So it's really no disclosures. I don't know if any of you are familiar with the story of Roy Sullivan. Unfortunate gentleman has the dubious distinction of having been struck by lightning the most of anyone on record, struck 7 times over the course of his life. Started when he was really young. Certainly, as you might imagine, he developed a certain paralyzing fear of storms and apparently became somewhat of a recluse over time. I mean, just incredible stories where he would, apparently at one point he was actually struck while driving in his car. There was a perfectly clear day, and while he was driving, a big cloud came up behind him, and lightning came into his car and struck him while he was driving down the interstate. So, one of the unfortunate complications of being struck by lightning, apparently, there's a lot of heat involved. He would catch on fire when this would happen. So he started driving around with a bucket everywhere he went. And I think sometimes it seems like our patients feel this way too. We have, these are rare diseases. You're told our most common disease is rheumatoid arthritis. In the autoimmune world, still only 1% of the population. So I think if someone's given a diagnosis of something like scleroderma, how unlucky can you be to have this 0.03% of the population diagnosis and then get another autoimmune diagnosis on top of it? So unfortunately, these things do commonly happen. About 25% of people with scleroderma also have features of other autoimmune diseases. So I wanted to kind of put a lot of things out there, some of which are immune-mediated, some of which are more symptoms, and some of which are just conditions that, due to the physiology of scleroderma, tend to happen together a little bit more frequently. What we talk about, let's see if I can figure this out. What we talk about when we're talking about overlap syndromes are these connective tissue diseases. This is kind of the group of what we refer to when we talk about autoimmune connective tissue diseases. You may also have heard of connective tissue diseases that are things like Ehlers-Danlos syndrome and a lot of times inherited defects in collagen. It's a little bit different than what we're talking about here. Of course, there are also actually, unfortunately, individuals with these autoimmune diseases also have a higher risk of other autoimmune diseases. So it's not uncommon for people to have other diseases like thyroid disease, certainly autoimmune liver problems, which I won't get into today. And then On blood work, certainly as well, a lot of things can show up. The scleroderma-specific antibodies tend to be fairly limited to individuals with scleroderma, although certainly I suppose I should be careful. Centromere antibodies in particular can happen in a number of other autoimmune diseases and liver diseases in particular. There are some other nonspecific antibodies. It can become very difficult to tease out sometimes what's scleroderma with muscle types of features and what's autoimmune muscle disease with some component of scleroderma features. So sometimes this gets a little bit muddy. Sometimes these antibodies can be found without any disease whatsoever. So it really does kind of run the gamut when people are getting initial blood work done. Rheumatoid factors, as I'll show you, are common in individuals with blood work with any kind of inflammation and are not themselves an indicator of joint disease. And similarly with CCP, this is another type of autoimmune protein antibody in the blood that we used to think was very specific to rheumatoid arthritis. I think we're reassessing that a little bit. Certainly doesn't necessarily mean that you're going to have joint problems with this kind of blood work positivity. And then fibromyalgia, many individuals can have this within autoimmune disease. About a quarter of individuals have widespread pain. It can become a little bit in the eye of the beholder sometimes because your pain is very subjective, and we're not always able to draw one-to-one connections between blood work and people's pain. It can be difficult to say what pain is from scleroderma, what pain is from fibromyalgia, but certainly we know that the experience of the pain and fortunately the treatments often overlap substantially, so we can get at treating these things without necessarily spending too much time thinking about what's causing what. This is just a big table here to give you a sense of how common these antibodies are. I think in rheumatology, we're used to this. I'm not sure how often patients see this. These are all, the first group of antibodies here are, now antibodies, I should back up a step. Of course, we all have antibodies in our blood. Generally, our antibodies are designed or selected to be things that help us fight off infection. So we should all have antibodies to things like the pneumonia vaccine. If we've gotten pneumonia before, we have antibodies to mumps, other kinds of diseases that we're fortunately protected for. These are antibodies that we don't quite know why we have these antibodies circulating around. Anti-nuclear antibody just means that there's one of these proteins that seems to bind to the nucleus of cells. It can be against any number of targets. About 17-18% of women have a detectable anti-nuclear antibody. So slightly lower in men, it's closer to maybe 12%. Of just healthy people. So certainly many of us have ANA antibodies just walking around, and you would never even know it if you didn't check blood work. It's a little bit of a hallmark, though, of some diseases. So if there's no ANA antibody, for example, we can feel pretty confident that we're not dealing with lupus. If there is the antibody, these things are still very much within the conversation because they're very common in these diseases. So in scleroderma, 95% of individuals at some point in time tend to be positive for an ANA test. And then about 20 or 30% of them have a rheumatoid factor positivity. A slightly smaller proportion have CCP positivity. And about 15% of patients have inflammatory arthritis, which I'll go into in a little bit. So again, these things are a little bit more common in folks with scleroderma. Not always pretending a diagnosis of rheumatoid arthritis, perhaps slightly increasing the risk of rheumatoid arthritis. But this is why many of our diseases are clinically driven. So we have to contextualize these blood tests because it's not enough just to have the blood work. As you can see, the blood work's a little bit all over the map. If we just check blood work without a context to put it into, it can be hard to put labels on things. And I think we can really worry people about a lot of symptoms that they don't have to worry about. So the first most important thing to do is figure out what's bothering the patient. And in scleroderma, we base the diagnosis of scleroderma in very large part just off the examination of the skin, examination of the blood vessels, listening to the lungs, listening to the story of acid reflux and bloating after eating. Some of these symptoms are very indicative of scleroderma-related problems. So in actuality, when we go to make kind of the formal diagnosis, you can really make the diagnosis just from the clinical picture alone if you're careful. To better be sure about what we're dealing with and to help figure out our treatments, tailored treatments, and of course look out for the complications that we have to watch for that can really get people sick. We do further blood testing. We can do imaging testing that looks for the evidence of deep organ damage. And then, of course, some individuals get biopsies. Sometimes joint fluid can help clue us into what's being caused by the immune system, what's being caused by crystals in joints, what's being caused just by wear and tear. All of these things are very common. And then, of course, many of our diseases, we don't just have one blood test for a disease. It would be easy in medicine. Maybe it'd be a little boring for us, I suppose, if all the tests were perfect. Maybe we could make a lot more progress quickly. That'd be great. But some of what I enjoy about rheumatology is that the symptoms, the clinical picture, talking to the patient is so important. The other causes as well can certainly cause many of these other symptoms. They can certainly change some of the blood work from time to time. So hopefully not many of you, but certainly it's possible that you guys have experienced various misdiagnoses or this is something we have to kind of take into account. And then finally, once we're sure that the symptoms that we're hearing about and the blood work are actually caused by our diseases and not something else, that's when we kind of have our diagnosis for various autoimmune diseases. So I'm going to tell you about the most common overlap syndromes in scleroderma. Sjogrens syndrome and Sicca complex. This is something that I think often we hear questions about. Generally, Sicca is just the Latin word for dry. So we can all, a third of us as we get older have dryness, which is probably just related to normal degenerative changes in our salivary glands with age. It's a little bit different when the immune system is what's driving the dryness, and that's when we start to call this Sjogrens. There can be primary Sjogrens, which is kind of standalone Sjogrens as its own autoimmune disease. And then anytime Sjogrens happens as one of our overlap syndromes, that's when we call it secondary Sjogrens. In the context of this is kind of most of what we're thinking about here. We treat the two very similarly. Sometimes Sjogrens can associate with deep organ damage, which is something that we always look out for. But the essential part of Sjogrens being the dryness, the damage to the glands that manage secretions is similar. Management for these things, we usually start with symptomatic management just because we don't have kind of a cure for the inflammatory damage that can happen with these diseases. So far, we don't have anything in clinical trials that consistently shows that we reverse the damage in the glands. So we're kind of left managing the dryness with things like artificial, if we're talking about eyes, artificial tears, cyclosporin eye drops. They can do, your ophthalmologist can sometimes do procedures to block the drainage of tears from the eye. These are punctal plugs, and if punctal plugs work well, that's kind of a temporary trial. Then they can do ablative therapies to those drainage systems. And then also for dry mouth, very similarly, there's trying to stay away from brand name products, but as far as I know, there's only so many players out there. But there's a number of kind of artificial saliva products out there. There are a few what we call cholinergic stimulants. So as we just heard, the cholinergic system is the nervous system that's responsible for a lot of motility, a lot of secretions. We do have medications that increase those secretions. They're not really dealing with the underlying immune problems, but oftentimes they can give patients some symptomatic improvement. And then, of course, with dry mouth, because the saliva is an important part of fending off infection and protecting the teeth, unfortunately, these individuals will need sometimes closer dental follow-up. There's high fluoride rinses that your dentist can use. There's a number of these kinds of approaches. Individuals with Sjogren's are at a higher risk for certain, but fortunately rare types of cancers, lymphomas. That's something that we tend to just keep a close eye on people clinically. There are some blood tests that we can do about once a year or so that maybe help us catch things a little bit earlier if, God forbid, that were to emerge. But it's not a perfect science, I suppose. Inflammatory arthritis, like I alluded to earlier, happens about 15% of patients. About 1 in 6 individuals will have arthritis, usually of the small joints of the hands, and that seems to be mediated by the immune system. So this is kind of on top of all the usual wear and tear things that we all develop as we go through life. Joint complaints are much of what we deal with in our practice. A proportion of these do have the positivity in the blood test, just like rheumatoid arthritis do. Clinically, there's a subset of people that have an indistinguishable form of rheumatoid arthritis on top of their scleroderma. I have pictures here. It's probably hard to see, but you might be able to tell. It looks like someone kind of took a bite out of this person's wrists. That's what we call an erosion that can happen in rheumatoid arthritis. And that's what we try to avoid. And this, fortunately, we've been dealing with rheumatoid arthritis as a specialty for 100 years. We have some experience with medications that seem to help work and actually reduce the risk of this kind of complication from happening. So we have to be careful because there are some other mimickers specific to systemic sclerosis that we don't want to miss. There's something called avascular necrosis, which is poor blood supply that particularly seems to happen to individuals with scleroderma in the wrists. Joint contractures are a common cause of joint complaints. When the skin gets really bad and the joints aren't able to move, that can result in kind of a permanent flexion deformity. And then, of course, acroosteolysis is the reabsorption of the fingertips due to changes in the blood flow and immunologic changes that once it happens, unfortunately, is more or less permanent, but that it can also be quite uncomfortable and something that has to be distinguished from arthritis. You've probably heard a lot of terminology thrown around. I just wanted to spell out here. I don't have a very good picture here, but there's undifferentiated connective tissue disease. I should have done a better job putting these in some tables for you. And then there's a disease called mixed connective tissue disease. And that's different from overlap connective tissue disease. So I would have a hard time imagining making this terminology more confusing. Undifferentiated connective tissue disease is a term that we often use for individuals that have features of autoimmunity. These are things that we deal with commonly as rheumatologists. They're things like Raynaud's syndrome, certainly dry eyes, dry mouth can go along with that. Sometimes blood work suggesting autoimmunity, things like an anti-nuclear antibody. But oftentimes there's not evidence of deep organ dysfunction or the kind of deep organ dysfunction that people have. And when I say deep organs, I mean the things that we have a hard time living without. So lungs, heart, kidneys. Or the pattern of that kind of involvement doesn't fit well into one of our immune diseases. Oftentimes, if we follow individuals with undifferentiated connective tissue disease, about a third of them will go on and develop a full-blown, kind of more classical connective tissue disease that fits our definitions, the way all of our professional societies define them. Overlap connective tissue disease is kind of independently these two different autoimmune diseases, say rheumatoid arthritis and then also scleroderma happening in the same person. We would call that overlap connective tissue disease. That can be a little bit hard to distinguish from mixed connective tissue disease, which is a very specific entity that was first described back in the 70s, where we found this one antibody, this RNP antibody, that seemed to denote a higher risk for a combination of arthritis in the hands, interstitial lung disease, so scarring in the lungs, Raynaud's syndrome, and sclerodactyly, or tightening in the fingers. That can be tricky because oftentimes they don't all present at once. So a great many people will have Raynaud's for many years, as many of your experience are, and a lot of the features with mixed connective tissue disease actually overlaps with systemic sclerosis. So sometimes that RNP blood test is the biggest clue that we have that we're dealing with mixed connective tissue disease rather than scleroderma. I should be careful because there very much is still a subset of scleroderma with an RNP antibody that involves muscle disease, a high risk of pulmonary hypertension, to an extent possibly a higher risk of lung scarring. So I'm probably not doing a great job convincing you guys, but unfortunately these things are messy. So again, we deal with this a lot. I suppose we're comfortable with this, but you can see where you may well be told different things by different providers, where maybe one day your one provider tells you it's mixed connective tissue disease, and the next day he uses a different terminology. Fortunately, usually we're talking about the same drugs for these medications. We're using the same drugs for the complications, if it's a lung scarring, if it's the high pressure to the lungs, pulmonary hypertension that we're dealing with, if it's the arthritis we're dealing with. The manifestation is often what dictates the treatment, not the bin that we're going to try to put a diagnosis into. So I think that's, I'm still verbal. I'm glad I think I made, fibromyalgia. So we have I think this is my last slide, yeah. So fibromyalgia, I just wanted to say a word about, I think many people come to rheumatologists and they've already had a fibromyalgia diagnosis. Sometimes before, when the disease is very early, some of your experience may play this out where scleroderma is not, always something that just kind of jumps up and shouts, I'm scleroderma. Many people have some very vaguely puffy fingers that if you don't look at a lot of hands, if primary care doctors may certainly have a hard time catching these things early on. And scleroderma, certainly we know that common symptoms among individuals with scleroderma are things like fatigue, widespread pain. These are common problems with the disease. There probably also is a link, though, with fibromyalgia, and some of this is the vicious cycle of fibromyalgia. Now, fibromyalgia is a functional disorder. We don't have a great explanation. We can't put up a diagram that shows you how various parts of the nervous system, like we had with kind of how the gut motility moves. We can't point to the individual parts of the immune system or the nervous system to tell you why some individuals develop fibromyalgia and some individuals don't. But what we know is that particularly in times of stress, particularly with decreased activity, a lot of times, among individuals that already have another reason for pain, you can certainly see how our individuals with autoimmune disease are going to easily fall into this high-risk group. With time, this syndrome of increased pain sensitivity, this dysregulation in the nervous system telling our brains that a stimulus, which should just be informational, the nervous system should just be telling our brains, this is where the hand is, this is where the leg is. Somehow that signal gets distorted and things that should just be touch signals become pain signals. This sets up in a vicious cycle because the less movement there is, the less that those sensory nerves have an opportunity to kind of re-equilibrate and just go about the day's business with the brain, and everything becomes kind of hyper-attuned to pain. And these cycles of pain with movement, predilection to, or difficulty kind of getting up and about and getting active can feed into this. You may have seen, your doctors may have pushed on you a lot, kind of trying to feel out tender points. That's one of our tools of feeling fibromyalgia. We have a sense of kind of what a normal amount of pain from a given amount of pressure should be. This can be helpful. It's certainly not necessary. And the newest diagnostic criteria for fibromyalgia have gotten away from requiring 12 tender points on a fibromyalgia exam. You actually don't even need the tender points. It's more about how crippling is the pain that an individual experiences on a day-to-day basis. Cognitive difficulties, which are very common, even in scleroderma alone, but also are oftentimes a feature of fibromyalgia. And how disabling these things are. So these scores, when severe, are all what feed into a diagnosis of fibromyalgia. Fortunately, we don't have to make too fine of a point of what the molecular mechanisms are. We know some things work very well for this. Certainly, physical activity works well for this. If I can force my patients to get out there, exercise every day of the week, they've done trials of this where they force people to exercise 5 days a week, 30 minutes, an hour at a time, and individuals feel better, and oftentimes better than anything I can do with medication. So there are FDA-approved medications for this that I've put up there, but activity is a big part of this. So it's something that I emphasize more than I do with any other disease, I think. So that's the landscape, I think, of other problems that maybe you've dealt with in the past. It's common to have multiple ones of these, so don't take heart, don't lose, don't get discouraged, I suppose, at any differences over time. We have treatments for most of these things, and I appreciate your time.